Hey everybody, John Malanca here with the Association of Cannabinoid Specialists. We have Dr. Jordan Tishler, MD. We have Adam Abodeely, also medical doctor, correct, Adam?
Yes, general surgeon and colorectal surgeon.
And
Yes.
Jahan Marcu, PhD as well. And so all part of the Association of Cannabinoid Specialists, having a casual conversation is how we talked about it with this new platform. So thanks for listening and thanks for being here as well. Last time we spoke about dosing, the importance of dosing, and that will follow into why a medical specialist is needed. Cannabis is not a one size fits all. It's unfortunate, not only here in the US, but overseas, the majority of doctors really don't know much about dosing, thinking it's a one size fits all, but it is not. What works for me, what may not work for you or your patient as well. And so that's why we're going to have this casual conversation for the need of medical specialists, not only being pro cannabis, but also understanding not only the benefits in a cannabinoid system, but the difference in age, weight, current health condition, the sensitivities, as well as drug to drug interaction. And so Dr. Tishler.
The whole point of the Association of Cannabinoid Specialists is really to help clinicians develop those skills, right? That, you know, we need to be taught these things. And there are those of us who've been at this for a while, and we have digested the medical literature, as well as, you know, countless patient encounters worth of experience. And the goal here is to make sure that everybody's playing from the same deck, that we all have the benefit of that, understanding that science and the clinical experience. And so we can go out and really address patients' needs in that, as you say, not one size fits all approach, and really to be able to sit down and understand that patients have complex histories, that they may be presenting to us sort of unlike a cardiologist. They may be presenting to us with a range of sort of seemingly unrelated illnesses, like, for example, arthritic back pain and anxiety and insomnia, which, you know, on the surface at least don't seem all that connected, but through the endocannabinoid system, we can influence all of the above. And then, you know, they come with complex medical problems, like perhaps they have heart disease, both, you know, coronary type disease or cardiac heart failure, and they may be on a range of drugs that may interact with some of the cannabinoid that we may be using, or it may be simply that if they get a reflex tachycardia from their cannabis medicine, it may outstrip their coronary supply and they might get demand ischemia, which obviously isn't a good thing. So all of those factors go into normal patient care. And I think in other fields of medicine, we kind of take that, I don't want to say for granted, but it's part of the job description. And somehow in cannabis medicine, for reasons that are historical but sort of irrelevant at this point, we've got this idea that the doctor just says yes, 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 no, yes, yes, no, you know, and then go off and talk to the bud tenders. But nothing could be further, I think, from the proper care of patients.
You know, the care of patients, you know, I speak at retirement community before COVID quite often, and I would ask that question: how many patients, because the stigma was there, I say, how many patients have actually had this conversation with a doctor? And it was a low show of hands. And I said, how come? They said, you know, one, I'm afraid to have this discussion with my doctor, but two, I've had my doctor, and this even happened to my aunt. I'm going to act, Mrs. Jones, I'm going to act like you didn't ask that question. And if I find out that you use cannabis, I'm going to recommend you go see another physician. And this one 80-plus-year-old lady said, I said, so what'd you do? She goes, I fired my doctor. And everyone laughed, but it was yeah, thumbs up. It was definitely a thumbs up applaud moment, because this is your health, and it's not illegal in most, not certainly in our country, but in most countries, it's not illegal to have this conversation about medical cannabis. And for the doctor, I think it does help to, if you're pro-cannabis or anti-cannabis, still at least do some education on this plant, because nowadays everybody is talking about it, from hangnails to acne to cancer. And so I think that's what part of this organization that we started is to have this conversation. And so for any of the physicians or medical professionals, PhDs that are out there that really want to learn, I think I truly believe that this is an organization that will help not only excel you in your practice, but with education as well. Adam, in your practice, I'll get to you shortly here, Jahan, excuse me. You clearly look like you're working for a hospital or a private practice. How did you get into this, and what made you look at cannabis as another tool in your tool belt?
Yeah, that's a great question. I'm glad you brought up the discussion about being employed for a hospital versus being a private practitioner, because that is one of the reasons that I got involved in this. Is I am in private practice.
Okay.
And I've been working with patients with medical cannabis now for about 10 years. And this was in New York State even prior to its legalization for medicinal purposes. And so having these discussions early on, as you mentioned, was quite challenging. But fortunately, as you know, with our cancer patients, with our inflammatory bowel disease patients, these are our patients for life. And so, they end up, gaining a certain level of trust. And early on, several of these patients had no problems talking to me about this and bringing it up. And maybe it's an area where I live up in northern New York where, cannabis was already, kind of being used, I guess, on the illegally, is certainly accessible, to kind of see how patients were approaching this. And when I first started talking to patients about it early on, I started to educate them about cannabis use, and most importantly, trying to get rid of some of the preconceived ideas out there that cannabis is a cure-all, and really seeing it as a way, as an adjunct to their treatment. Particularly early on with cancer. Of course, I still have several patients who tell me they believe that the reason they beat their cancer is because of cannabis. And I like to believe that there is, some truth to that, but we know the reality is that, we don't have all that science and all that data yet. So, having said that, it was very hard to dispute the fact that patients said, well, there are several other reasons it was beneficial for them, whether it be for chemotherapy-induced nausea and vomiting, which is one of the indications that we do know that we have some pretty good science on. Pain, of course, cancer can be associated with pain, and I think a big part of that too was just quality of life. And we do hear a lot of patients that use cannabis. They say it helps them from depression and anxiety, and certainly cancer patients could experience a lot of that, as we could all imagine. But early on, when it became legal in 2016 in New York State, about a year prior to that, when we started to get some wins that this was going to be becoming legal, I got asked if I was going to be a certifier in New York State. We are considered certifiers. We certify patients who we deem to be appropriate candidates for medical cannabis. And initially, as a surgeon, I don't want to say I didn't have an interest in doing it. It just didn't feel that it was in my, repertoire, or should be in my repertoire as a surgeon. But what I came to realize quite quickly is that anybody who was employed by a hospital and received federal funding was not allowed to have these even discussions, or all they could do was just refer. They would say, well, I can't talk about that. I'm going to refer you to Dr. Abodeely, because he's in private practice and he can openly talk about this. I can't, and I certainly can't certify patients because I'm receiving, part of my income comes from federal funding.
Yeah.
So, it was really interesting to see how this all came about. And really, my practice just really developed, the cannabis side of really developed because of that sheer fact that, a lot of doctors were not even allowed to talk about it. And, we are seeing definitely some changes. This discussion to me is a very important one, because I've kind of lived, as I'm sure a lot of you have too, have lived through this evolution of cannabis medicine. And, we've seen how we've had lots of people who have been opposed to us doing it. And you could probably imagine as a surgeon, even more so than, surgeons like to cut, surgeons like to operate. And seeing how we could not only improve the quality of lives of patients with inflammatory bowel disease and cancer, but maybe even keeping them out of the operating room, maybe keeping them, maybe decreasing the amount of medications they have to take, whether it be for pain, whether it be for symptom relief, or whether it's actually assisting in the inflammatory process. But when I think about the discussion around why should doctors be involved in this, I can think of multiple reasons why doctors should be involved in this, and some of these we've already kind of touched on. The first is that there is a huge difference between recreational cannabis use and medical cannabis use. And Dr. Tishler has said multiple times, I've heard him say this, and I couldn't agree with him more, is that patients who are using cannabis for therapy don't necessarily want to feel high. They just want to feel normal. They want to feel better. And a lot of people don't want to feel that high. And so, that is one of the main reasons I think that we are extremely important in this evolution of cannabis-based medicine, because the dosing for recreational tends to be much higher, I found, than for medicinal applications. And if you were to go to if someone with an illness were to go to a dispensary and talk to a bud tender, they're probably going to get some different information than for those of us who are used to dosing this at usually lower doses than people who are looking at for the recreational side. So, before I continue on my list of some of my things other reasons why I think this is important, I thought maybe I could just, open that up for other people to discuss that as well, because I think that is important. And Jordan, you could probably comment on this as well with regards to, to dosing, which is, very different recreationally than medicinally. I mean, I see people recreationally using doses of even hundreds of milligrams, where, I find that, some of our patients, particularly those who are using it as an adjunct to their opioids, or just symptom relief, we're dealing with somewhere between, on average, probably 5 to 15, maybe up to 20 milligrams of THC. So that's very different. And it's in the same way we prescribe medications where people may not know the effect that's occurring. So if you take a cholesterol medication, you're just going to be waiting. You don't know it's working until you get your blood drawn next time. Where somebody recreational is taking it, well, they're going to know that it's working once they feel high, but they may not need that high dose, or that higher dose may actually be a detriment to what they're trying to treat.
Absolutely.
You brought a great point here. And sorry, Jordan, is, people always ask, I want the medical portion of the plant, not the recreational portion of the plant. So I don't want people to be afraid of THC because of the benefits that all the cannabinoids play. And like you said about not feeling, I share with people, the goal is not to be high. The goal is for you to be healthy. Same thing with vitamin C. If you take, your 1,000 milligrams, great. You take 10,000 milligrams, you're going to be sitting on the toilet with the runs. And so, less in a lot of cases is more. I work with a lot of physicians that work for institutions that are afraid to have this discussion because of federal funding. But I do have a lot of doctors that work for those medical institutions that call and say, I made a promise to my patients and their families for the patient or the child that I do some research. And I applaud those doctors that do step outside the box and want to learn about this. Not giving false hope. Hope is great, but false hope is something that I believe that all of us have the same mindset. I've seen this plant work. I've seen it not work. Definition to me is saving a life. Definition to someone else's end of life care, getting off opioids, sleep, anxiety, depression. And one other thing, and Jahan, I know you're here, so I apologize. Talking about you being a recommending physician. That's the part that's frustrating in a lot of other states too, where they can take a 6 or 7 hour class and go, Mr. Jones, now you are a recommending physician. What do you know about it? Not a darn thing, and I think that's doing a disjustice for not only themselves, but also for the patients, that the physician really is not up to speed with what's going on. Jahan has been in this industry quite some time. Like me, we're the youngest pioneers, if you want to say. who can't grow facial hair, so I'm jealous at him. No, I just shaved after a week. I just shaved this morning, so it's nice to see my face again. But Jahan, you speak a lot about safety and testing, and I think a lot of doctors are afraid about that, saying, I really don't know. I know I'm safe when I recommend it for a pharmaceutical, that each and every time it's going to be across the board the same, but it's not like that with cannabis. And so can you share some of your expertise? Because you've spoken about this quite a bit, not only in the US, but globally, about safety and testing.
Sure. And I think we can, tie that into some epidemiology studies. So there's been several that look at comparing different groups. So to kind of try and tie in some of that safety data with some epidemiology and what we're talking about here, a recent study was published in the Journal of Drug and Alcohol Abuse using the National Survey on Drug Use and Health data. So they looked at about, over 17,000 people age 50 or over, non-medical and medical cannabis users. How healthy are they? How do they use cannabis? Where are they getting it from? And just to kind of comment on some of the things that we've been talking about, one is that what's interesting is the people who check the box that say they were using it for medical reasons, 21% of them said they did not have a doctor. And of those with doctors, a third of them basically said they did not inform their doctor. And basically, another third of said their doctor was neutral on the issue, but about 8% reported their doctor was not supportive. So I think and that's just in the medical cannabis community. That there is a sort of even a reluctance, if you do get certified, to discuss, issues with the product or things you're trying to address with the product. So that becomes an issue. And I think part of the reason is it's complex. We don't have uniform labeling on these products. And so, they've done studies where they show regular cannabis users a universal symbol for cannabis. And it always cracks me up that there's something like 10 universal symbols for cannabis. It's almost like professional wrestling where they have like 10 different champions. And it's like, is this a prop or is it an actual thing? Sometimes it's hard to tell when people have strange definitions of things that you're not familiar with. So among the 10 universal symbols for cannabis, people can't identify what they mean or what they are, also because people aren't educated to identify them either. So I think that's an issue when you're distinguishing between a THC-rich product, a CBD-rich product, just as one example of basic label awareness and being able to read a cannabis label. And that's one of the other important reasons for going through a regulated source, is to be able to, get a product that meets certain standards. So when you look at the label, it adds up. Everything that's reported should be reported on. And I think some doctors, and I've seen these reports, I'm sure you have, there's been case reports where doctors have posted things that their patients have gotten from the illicit market. Cannabis filled with lead shavings to make it heavier, filled with glass beads, tiny glass beads to make it weigh more and be shiny, cannabis contaminated with mold, and so on and so on and so on. And so the illicit market, where quality control, patient safety is not a priority, I think that's the kind of the stigma and the education we have to get over, is really educating people that there are standards for labeling, that different states might have different standards for labeling, but they all come down to a couple common denominators. But they're, and I think having more medical professionals involved with label education. And so a place to start, maybe Jordan, you could comment on, or possibly, Adam, you see patients as well, or we're considering seeing patients, would it be helpful if patients brought in their packaging for the product, or send it to you so you could help them make sense of the dosing? Because maybe you can't say, what you need is 10 milligrams of this gummy bear or whatever. You can't be that specific these days, but I think a great place for patients to start, especially if their use is legal and covered under state law, is to bring in packaging and say, talk to me about this product, the pros and cons of using this. Because I think that's where people get confused, is how much THC is in this. Could this have Delta 8 in it? Yes, if you bought it outside of a licensed operation. Sometimes in these products, things are, and most people would even be shocked to learn that if you get a standard hemp chocolate bar, it's like 43, 46 grams, something like that, there could be over 100 milligrams of THC in that, and it's not even on the label. So it just says like under 0.3%, wink, wink, nudge, nudge. And then meanwhile, yeah. And so you eat enough of it, it'll behave like a product more potent than a product you could buy in a single unit dose in the regulated market, which is 10 milligrams per dose. So there's these like, Alice in Wonderland through the looking glass moments with product safety. And so, basically my point is, I don't think the best way for a patient to have a conversation, or a consumer, even an adult use consumer, is just casually. It's bring in a product label and say, I've heard about this, or bring out an advertisement from a product that has a label and say, I've heard about this. I'm thinking of using this, and maybe having the conversation a little more objectively that way, about the product itself, where it's coming from, what is known. Maybe bring a certificate of analysis for the clinician. I mean, I don't know, Jordan, if you've ever dealt with a patient, or Adam, where they brought in like, oh, I have the certificate of analysis of a drug I'm taking.
I do this all the time, as a matter of fact. So, you said something about, I don't know if you can be so specific to say you need 10 milligrams of this product. I do that all the time. Nobody leaves my office without that. This is how many milligrams. It's usually 5 to 10 milligrams, and I give them a written protocol. You start with the 5 milligrams, and you do it this way for a set number of days. And then if you need to, we'll go up to 10 milligrams. And if 10 milligrams isn't enough, then I want you to call me or email me, actually. But yeah, I mean, it's this product, this amount, just like it were, Lipitor or something else. And I write it down on something that in any other universe would be a prescription, meaning it's got my name and it's got my office address and their date of birth and their name and instructions: buy this product, use it this way and buy this much, and it's got my signature. In any other universe, that would be a prescription, but not in this universe. And I think that's really important. And the idea of just sort of sending people down to talk to the bud tender at this point is really malpractice, right? I mean, we wouldn't do that, with the Lipitor. You wouldn't be like, go get some cholesterol meds and I'll see you in a year. To let you know.
Go talk to the Rite Aid cashier about your medication.
Exactly. This just, and thankfully, in the Rite Aid or in the pharmacy world, they're trained. If somebody asks you about their Lipitor, you got to zip it and send them to the pharmacist, and the pharmacist has whatever she and he can say about Lipitor. But if it gets into not just Lipitor, but your cholesterol and your disease process, they have to send you back to your doc, because that's where the appropriate information comes from.
I guess what you never want to hear is, I don't know how that works. Go look on YouTube. Like, I think that'd be a bad way to go about the education.
But it happens.
Yeah, I mean, as a supplemental source, I'm not knocking YouTube. There's YouTube University or whatever, but I think that happens a lot, and there is some good content out there. But if you're new to it, how do you sift through and tumble through what's good information and what's potentially harmful information?
The nurses of the world are far better organized than we physicians, and one of their slogans is "Everybody deserves a nurse." And that's great, but I think everybody deserves a good doc too, somebody who knows the science and understands the medicine, and who, and this is, I think, the part that's lacking from medicine in the United States more broadly, is somebody who can sit with the patient and hear what they're telling you of their illness and their experience with the treatment. That's part of the reason I went into private practice after years in the VA, was because this really allowed me. Actually, the ED where I worked for forever was good for that too, because when it wasn't an emergency, but I was unfortunately diagnosing cancer in a patient who had come in for something, I could spend the time, I could sit at the bedside and really listen to them. And that's really important to me. John, a while back, you kind of used the phrase pro-cannabis or anti-cannabis. And it's an interesting construct to me, because from my point of view, I am neither pro nor anti-cannabis. I am pro-patient, right? And for me, everything flows from that. If I am pro-patient and cannabis works for a particular problem that they have, why would I not use this? And if, on the other hand, I am pro-patient and cannabis doesn't work for that problem, or that patient has some contraindication, like, sure, they have back pain, but they also have unstable bipolar disorder or schizophrenia, then I would not use cannabis for that patient. And I would say, look, in this case, you should be using conventional medications. Another great example is glaucoma. Every freaking state has glaucoma on its allowable list, but we know full well that cannabis or THC decreases intraocular pressure for 2 hours at a time, which means you need to be smoking a fatty every 2 hours, even during the night when you're supposed to be asleep, versus you use some conventional drops in your eyes twice a day and you're fine. So, there are times when, as a non-cure-all, conventional meds might be better. But then there are those cases where cannabis is at least as good, if not better. And opiates is an obvious example where cannabis can be better in certain circumstances and less dangerous. So then we should be using it.
I think that's where we all agree on, as I mentioned to Adam as well, is adding this into your tool belt.
That's it.
I mean, there's a lot of times patients call us and I route them away from cannabis. They say, well, you're a cannabis guy. I said, our goal is patients first, as you were mentioning. I mean, that's what United Patients is, patients first. I'm a health and patient advocate, and I've seen higher success doing this. You can use cannabis as a Band-Aid, and I'm the first to say, I'll never use the word cure, but also the first to say that, never want to give anybody false hope. I've seen, like I said, I've seen it work on many ailments, including cancer, and I've seen it not work on many ailments, including cancer. Jahan, I want to go back to your list of 10 things on the labeling. It is confusing. It's confusing on different states that they have this. I get this all the time. What's the difference between milligram dosing and milliliter dosing? I get the same thing of, back in California. So California was legal medically since 1996. Back in 2000, I want to say 16 now is when they went recreational adult use. I voted no on it. A lot of people got upset with me about that, but what I'd seen and witnessed in other states, Colorado, Washington State, Oregon, it's pushed out the true medical doctor. And now patients, as you were saying, Jahan, are, 20, 30% are going down and just not talking to their doctor and say, I'm going to go down and get this. Next thing you know, they walk out with 5, 10 different products. A lot of times, work on the sleep and everything has a domino effect when it comes to pain, anxiety, depression, et cetera. And so I think that's another reason why I truly believe medical professionals should be involved at all levels. And that's what I share with, we were all 20 once. We were like, won't do that again, and there's some things. I'm 54 this year. It's like, now I haven't touched it since I was 20, because you're like, but a lot of cases with the seniors, they've had this stigma their whole life about cannabis. One, they're afraid to ask their doctor because, like, gosh, I've been against it my whole life, and now I'm asking my doctor about it, and I'm more embarrassed about that. And so I just think bringing that stigma down and having that discussion is huge. Lester Greenspoon, another Harvard medical doctor, he passed away. I think his anniversary was last year of him passing. He was an advocate on talking about cannabis and bringing that stigma down. He was someone, I believe in it, but I'm going to do the medical background and show the medical side of that. And so he's opened a lot of doors for people. So I do a lot about, remembering pioneers in this industry. And I just recently did that. And I don't want the pioneers to be forgotten who have paved the way for many of us with that too, and educating. And I think education is huge. You were going to say something, Jordan. Sorry.
I was just going to say Lester was a mentor for me, and
Gotcha.
So very much I think that the educational efforts that we're making through the association and the work that I do with my patients very much sort of a tribute to what he's contributed to us.
For our listeners that are new to the Association of Cannabinoid Specialists, what would you recommend them doing? How, getting education, signing up, joining? What steps would you think? Like Adam, how did you find Jordan?
That's a great question. I don't know if I know the answer to that, other than, coming across his association and reaching out to him. And, early on, I realized that, we shared a lot of the same common threads when it came to not only talking with patients, but also talking to other providers. And, going back to the education thing, I think there's also a difference between education and proper education as well.
Yes.
And, the classic example that I always give this now is there's a condition that certain patients who use cannabis can experience called cannabis or cannabinoid hyperemesis syndrome, where, So a small percentage of people, will suffer from, severe intractable nausea and vomiting with their cannabis use. And being a GI specialist, I can't tell you how many times people go to the emergency room now and they're throwing up, and one of the providers in the emergency room finds out that they use cannabis, and they say, you have cannabis hyperemesis syndrome, so you need to stop that immediately.
Right.
And it's really unfortunate, because these people are people that I may have recommended cannabis for a variety of different reasons. But, they'll come back to my office, and clearly they don't have classic symptoms of cannabis hyperemesis syndrome. And, they may have been a month without being able to use cannabis because the emergency room physician said, you have cannabis hyperemesis syndrome. And, I work them up in the office and find out, well, it's their gallbladder, or they've got peptic ulcer disease, or, gastroparesis, or one of these other conditions that, they probably would be throwing up and feeling sick if they were not having cannabis. And, to tell a patient who's receiving chemotherapy that it's the cannabis that's causing them to vomit, has been discouraging for me. But that's where it comes into proper education. So, I've done some own internal educating within our institution here to teach them about that, because when cannabis first became legal for medicinal purposes here, I'm not sure where they received this information from, but clearly everybody who came into the emergency room that was having abdominal pain, nausea, and vomiting, if they used cannabis, they were told that they had cannabis hyperemesis syndrome. And that, was really a detriment to, patient's care.
Absolutely. You're absolutely 100%. And, as a reformed emergency room doc, I find it disheartening that so many of my colleagues are taking this knee-jerk approach. The other thing that I think we should talk about in light of why we need to keep medical professionals in this and educated is that cannabis can be a harmful medication. You talked earlier about recreational users using very high milligrams, and we have to acknowledge that particularly at those high doses, people can develop significant tolerance and dependence, and in the worst case, in fact, cannabis use disorder. It's a real thing. I think that between the industry and the advocates, there's sort of this, no, that's just, prohibitionist talk and stuff. And, clearly it has been used in prohibitionist discussions, but it doesn't mean that it's not a real thing. And unfortunately, even in my very buttoned down prescribing oriented practice, I have seen the influence of the industry where more is more. And there's a lot of encouragement to buy and to dabble in other products and higher doses. And I've seen patients, end up starting to use concentrates and getting themselves really into trouble. And then I end up as their physician, not only trying to treat whatever we were treating, but now trying to treat their burgeoning cannabis problem. And it becomes much more complicated to help somebody bring their tolerance back down and use safer dosing, all the while, continuing to treat whatever the primary set of symptoms were that they came for, right? And in some ways, in the recreational world, they say, oh yeah, just take a tolerance break. You can't really do that with somebody who's on chemotherapy, right? So you really want to avoid getting into that problem in the first place. But if you do end up there, it becomes very challenging to try and help them get back into a more healthful place.
And yeah, Jordan, if I could comment on that as well, I think that's a great point, because although we know that, that cannabis is, definitely a lot safer than, high dose opioids and all these types of things. One of the things that I've seen out there is that, there's a few different types of cannabis doctors. There's those of us who really care about doing the right thing. But what I'm concerned might happen is, I've seen it happen, is that there are some practices out there where it's a mill, it's a factory for, not about doing what's necessarily right for the patient, but getting as many certifications or prescriptions as you can. And, to your point, Jordan, cannabis, if not used properly, could have some potential side effects, unwanted side effects. And it's the same situation that got us into trouble with opioids. There were too many doctors out there that felt that, Listen, this is about the success of my practice and not necessarily the success of patients. So I'm going to get as many people in the door as I can to write prescriptions. And, we know now that that was a bad idea. And so it's just one of the other reasons I think it's, extremely important that, doctors not only, maintain a certain, a high level of involvement in this, but are also, receiving the proper education, and that we do keep some sort of tabs on, who's prescribing and how much are they prescribing, and why are they prescribing, because we certainly don't want to see a cannabis factories and mills, if you will, because we could potentially run into a lot of the same problems that we did with opioids. Fortunately, like I said, opioids are not are certainly much more harmful than cannabis. I certainly believe that. I think everyone else probably believes that as well. So
yeah. I think one of the things that I would say is that, one of the premises of the association is that physicians should actually be prescribing this instead of this sort of yes, no certification stuff. And I think part of the reason for that the obvious reason is because then hopefully the patient gets the right medicine and, the industry stops twisting their arm. But I think the other part of it is that physicians then, in writing the prescription, have to step up to the plate and take ownership of that prescription and make sure that they're properly educated. Otherwise, they're going to be facing a blank prescription and going, I don't know what to do, right? And I'm thinking that hopefully that will dissuade some of those folks that work for the mills and really encourage people like yourself to, to join in the process of taking care of patients. Jahan, were you going to say something?
No, I just agree with what you're saying. And I think, it kind of goes both ways, but yeah, the consumer, the patient has to have confidence that their health professional will at least treat the subject objectively. And that doesn't mean take a neutral stance. It means have an objective conversation, about risks, about benefits, and the potential aspects of those and factors that go into that. So yeah, I would agree with everything we're saying here. Yeah, so that, and yeah, I think it's to me, having been in this for a long time, sometimes it's oddly humorous how long this conversation has been going on about, whose responsibility is it to have the conversation. And it's really odd that we put it on the lowest paid entry level employees sometime, the bud tenders. Which in some instances works great if they happen to have some sort of health background, as well as some access points do have nurses working there and pharmacists working there, at least able for a consultation. But it seems odd that we would have to make that requirement. It seems odd to, but that's just the way it is. We have to create a regulatory structure too that allow these things to flourish. So it's up to health professionals also to participate in the regulatory process, to make their voices heard, participate in open comment sessions, and not just like, we have no science, we have no data. I mean, it's just, at this point, it just sounds like a crazy person with a sandwich board and a bell walking around, like, beware the AMA, we have no science. And meanwhile, it's like you go on any sort of internet search, you're like, wow, there seems to be tons of data. But maybe it's not on the subject of your choice, but there is a ton of data. Like I just mentioned a very large epidemiological study where use between users and non-users being tested and, and explored. And that was published by researchers from Texas. So, I think that there is so much research that it's hard to know how it fits in, how to filter it, and how to apply it. Now that there isn't any, when it comes to specific things like what is the toxic lethal dose of cannabigerol, well, no one studied that because nothing has really documentedly died unexpectedly from consuming it. So there are issues there around gaps in research, but do we have a lot of data to start making decisions about certain things?
Exactly.
Yes, I believe so. And I think we should not also, when it comes to states that have chosen adult use or medical routes, like John said, sometimes it isn't right. Sometimes the regulations aren't right, and you have to vote against it to get something you wanted, even if it means delaying access a little bit. And some states that have decrim now have this unique opportunity to go through a tug of war, say, what do we want? What's best for our program? I mean, here's something that's kind of funny to me is like, oh, they're going to let people grow cannabis in Manhattan, like for their own use. I'm like, the average square foot of an apartment's like 380 square feet. I mean, I'm exaggerating, but who's going to grow a bunch of plants in a tiny New York apartment? So it's like, yeah, we'll let you grow your own plants. but you know, in an agricultural zone, you know, like Northern California, they maybe don't want people to do that because there'd just be like so many plants everywhere. So, you know, that's like what works best. And I think now when regulators make their decision, I think we have to hold them to what data are you doing? How are you gathering your data to make these decisions? And, you know, it's really odd. Like it's just like, I'm going to take all of our patients' needs and desires and put it on 22 black. That, you know, it includes like whether or not you have delivery, whether or not you require testing, the types of products available, the number of licenses to give out per capita, which is like, you know, oddly enough, sometimes it's just a number picked out of a hat or just something that's chosen and you spin the roulette wheel because everyone agreed on it, regardless of what data there is to support certain policies. And I think the biggest lesson, and it's one that clinicians and health professionals need to get used to, is that you can't start putting arbitrary bans on products, percentage limits, this, that, or the other, because it's a menu for the illicit market. If there is a need for it, the unregulated and illicit markets will exploit it. Look at Delta 8 THC. Now, this was available in the regulated THC industry, regulated medical and adult use cannabis for a long time. You know, not advertising, but specifically Mary's Medicinals, one of the first companies to offer a Delta 8 product. The illicit market has gone through this pathway of like being like, oh, well, we can do that too. But, you know, this brings up the safety thing, John, just to kind of tie it all together, is that if you're not going to talk to your patient about, say, cannabis derivatives, they might go get a CBD product, not knowing that deriving it from THC in a legal manner, or like licensed manner by that state licensed manner, it's actually a much more straightforward and safer, cleaner process than trying to do it with CBD, because of the nature and difference of THC to CBD. One is, you know, through CBD to Delta 8 produces a lot of like side products. It's not a very, very pure product. Whereas Delta 9 to another isomer of Delta 9 of THC is very easy and very straightforward. And, you know, I know that's a little bit nuanced, but these are the conversations that you just have to have sort of like introduce patients to principles like this is safer, this is less safe, and things like that. And I think letting the consumer or patient start to make some decisions with an informed sort of just partially agree, definitely don't agree, you know, just to give them some more guidance on this. Because and clinicians with cannabis too, another, I think, a principle is that patients may not stick on a product, as you kind of mentioned, Jordan, is they might move around, especially the first couple months of being a patient, what works, what doesn't work, change up the dosing or change up the potency, trying to like play with different parameters of the plant in terms of like terpenes and other secondary compounds to stay low on the dosing and to go slow on the dosing, to paraphrase.
Or even how they
lot.
consume, or the or their modalities.
I gotta interject here and suggest that patients should be talking to their physicians before
absolutely
changes, because that's, in fact, you know, in some ways there's an issue of there's what the industry wants, and then if we kind of tacitly agree to that, then we're kind of giving them the runway to manipulate our patients. And you know, as we've seen, that can lead to patients getting, you know, poor outcomes as well as high risk, you know, complications. So I think that, you know, I think there are maybe some products that I think that shouldn't be available through the regulated market. But ultimately, I agree with Jahan's basic premise, which is that if we're educating our patients properly and we're following them closely, and best yet prescribing this as opposed to just saying go talk to the bud tender, then I think we're going to set them up for the best possible outcomes. By the way, just as an aside, we're nearly completed our bud tender training course. So that should go live sometime in the next few months, and we'll see if we're able to get some of the bud tenders out there up to speed in a more CVS or pharmacy oriented approach to caring for the patients who are in front of them.
I hope so. Two things, Jahan, you were talking about lawmakers. That's one thing that I have spoken about for years. Crit and I would say these lawmakers, because each state has their different qualifications. What works, you know, you have your CBD only law states where cancer is not qualified. 2 children, one is pediatric epilepsy, one's pediatric cancer. The pediatric cancer patient's illegal. Really? New York was like that with cancer, right? Cancer and pain, and a lot of doctors go, wink, wink, you have pain, right, Dr. Jones or Mrs. Smith? So I would always talk about, I'd always talk about, before these lawmakers make these laws, that they should get educated on this. God forbid something happens to, as we all know, cancer or any ailments do not discriminate. Doesn't matter what your background is, doesn't matter how healthy you are, how wealthy you are, how sick you are, or wherever. It's something that I believe everyone should, if we are going to be, as it's making its way across not only the US, but globally, this topic should come up here too. I know we need to wrap this up, and I want to throw this back. We always talk about the negative and the non-benefits of opioids. I work with a lot of patients. I work with a lot of neuropathy groups, both in cancer and diabetes, and a lot of nurses that Jordan and Jahan and I work with as well. One in particular has fibromyalgia. She was never a cannabis patient and been battling it for 22 years. She found, oh my God, this is the first thing that's helped me. I get up at 3 or 4 in the morning to get out of bed at 6 in the morning. I mean, I don't experience pain, thank goodness, and I hope you don't either. But what she has found, instead of having a 25 milligram opioid, she's able to take 2 to 3 milligrams of cannabis and bring that opioid down to 5 milligrams and have the same benefit of a 25 milligram. And so I don't want people to push people out saying opioid, bad, bad, bad. And again, knock on wood, I'm very fortunate I don't have to take any medications. And so, but those are the patients that we really fight for as well. And I just think that's part of what this talk is about. And so, Jordan, it's an honor to be on this board with you, Adam, Jahan, and this conversation. And so for any medical professional at any level, MD, PhD, DC, osteopaths, I mean, the list goes on, RNs, nurse practitioners, we welcome you. We welcome you to keep this conversation. And I always talk about it's the pebble in the pond, the ripple effect of education and getting it out there. Something like this could help you or your patient. And so I thank you for taking that stand and being brave and coming out of the cannabis closet and saying, I'm sticking up for myself here too. And so any closing words?
Let's mention where people who might be watching this can find us so that they can get all of this good education. So the group is called the Association of Cannabinoid Specialists, and we've just changed the URL actually of our website. So it's now cannaspecialists.org. So it's a little shorter than it used to be, cannaspecialists.org. And at that website, you can find a whole bunch of introductory material about what we're doing and also about delivering cannabis care. And if you choose to join us, then there are a whole raft of benefits, including mentorship and educational opportunities, and a library full of important studies and some handbooks so that you know exactly what to do for each situation. So please visit us at cannaspecialists.org and join us and help us continue the education and the advocacy in DC.
Wonderful. So Dr. Jordan Tishler, Dr. Adam Abodeely, I'll say Dr. Jahan, excuse me, you're a doctor, my apologies, Dr. Jahan Marcu and John Malanca for the Association of Cannabinoid Specialists. Thank you again for another casual conversation with us, and we'll see you next time. Have a blessed day, everyone.
Thank you.
Bye-bye.